Good morning, everyone, and welcome. This is Grace Lee, Chair of the Advisory Committee on Immunization Practices. Today is September 1st, 2022, and I'm pleased to call today's ACIP meeting to order. I'm also pleased to announce that we did not meet in the month of August. I will turn it over in the beginning to Dr. Melinda Wharton, our Executive Secretary for ACIP, to share today's announcements. Dr. Wharton.
Thank you, Dr. Lee. Next slide, please. Before I go into the meeting logistics on the slide, I just want to let the attendees from the public know that although this meeting was announced as a two-day meeting with a 2-hour session tomorrow morning, we do not anticipate using that time. Our expectation is that we will complete our business today and adjourn at the end of today's meeting. At the time the meeting was scheduled, it was unclear to us exactly when the FDA would complete the regulatory action, and we thought it might be necessary for us to vote tomorrow morning. But as probably almost everyone knows, the FDA did get the regulatory actions completed and before the meeting, and so that's not necessary to do, and we expect to be able to complete our business today. So I think we're all pleased that we will have only a one-day meeting. So I'll proceed with the meeting logistics on the slide. Good morning and welcome to today's hopefully one-day, September 1st, virtual ACIP meeting. Copies of the slides are being presented at today's meeting are available on the ACIP website. Additionally, slides are available through a share file link for ACIP voting, Liaison, and Ex-Officio members. A few notes on meeting logistics for those of you who are listening in on the Zoom line. Please mute your lines at all times until you're called on for discussion, and when Dr. Lee opens the meeting for discussion, please use the raise hand function in Zoom to virtually raise your hand. During the discussion period, Dr. Lee will take questions first from voting ACIP members and then from Ex-Officio members and Liaison representatives. We ask the Zoom participants to disable their video and but for ACIP members to turn on their video during the votes. Next slide, please. The Advisory Committee on Immunization Practices is, at its heart, a public body, and engagement with the public and transparency on our processes are vital to the committee's work. For this meeting, we'll be holding one oral public comment period at approximately 12:15 Eastern Time. To create a fairer and more efficient process for requesting to make an oral comment, we ask that people interested in making an oral comment submit a request online in advance of the meeting. Priority is given to those advance requests, and if more people request to speak than can be accommodated, we conduct a blind lottery to determine who the speakers will be. Speakers selected in the lottery for this meeting have been notified in advance of the meeting. Members of the public can also submit written public comments via regulations.gov using docket number ID CDC 2022-0103. Information on the written public comment process, as well as information on how to make a comment, can be found on the ACIP meeting website. Next slide, please. As noted in the ACIP Policies and Procedures Manual, members of the Advisory Committee agree to forego participation in certain activities related to vaccines during their tenure on the committee. For certain other interests that potentially could enhance a member's expertise while serving on the committee, CDC has issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but these members are prohibited from participating in committee votes on issues related to those vaccines. Regarding other vaccines of a concerned company, a member may participate in discussions with the provision that he or she abstains from all votes related to the vaccines of that company. At the beginning of each meeting, ACIP members state any conflicts of interest. Next slide, please. And with this, I will turn the virtual podium over to Dr. Lee. Thank you.
Thank you, Dr. Wharton. We will proceed with today's roll call. For the ACIP members, I'll ask that you state your name, your affiliation, and whether you have any conflicts of interest. We will start this morning with Dr. Lair.
This is Dr. Jamie Lair. Good morning. I'm a family physician in Ithaca, New York, and I have no conflicts of interest.
Thank you. Dr. Chen.
Good morning, everyone. Wilbur Chen, Professor of Medicine and adult infectious disease physician at the University of Maryland School of Medicine. I have no conflicts.
Thank you. Dr. Cotton?
Good morning, Camille Nelson Cotton. I am the Clinical Director of Transplant and Immunocompromised Host Infectious Diseases at Massachusetts General Hospital and Associate Professor at Harvard Medical School. I have no conflicts. Thank you.
Thank you. Dr. Bell?
Beth Bell. I'm a clinical professor in the Department of Global Health at the University of Washington, and I have no conflicts.
Thank you. Ms. McNally?
Good morning. Veronica McNally, president of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Thank you. Dr. Talbot?
Good morning, Kit Talbot. I'm an adult infectious disease physician, and I have no conflicts.
Thank you. Ms. Bata?
Good morning, Lynn Bata, public health nurse with the Minnesota Department of Health, and I serve as the clinical consultant, and I have no conflicts.
Thank you. Dr. Paling?
Good morning. This is Kathy Paling, and happy September to everybody. I am a professor of pediatrics and epidemiology and prevention at Wake Forest School of Medicine, Atrium Health, Wake Forest Baptist. I have no conflict. Thank you.
Thank you. Dr. Sineas?
Dr. Sybil Sineas. I am an internist and pediatrician. I'm an associate professor of medicine and pediatrics at the Warren Alpert Medical School of Brown University, and I have no conflicts.
Thank you. Dr. Daly?
Good morning, Matt Daly. I'm a senior investigator at Kaiser Permanente, Colorado, and an associate professor of pediatrics at the University of Colorado School of Medicine, and I have no conflicts of interest. Thanks.
Thank you. Dr. Brooks?
Oliver Brooks, Chief Medical Officer, Watts Healthcare Corporation in Los Angeles, and I have no conflicts. And good morning to everyone.
Good morning. Thank you for being here, Dr. Brooks. I'll go ahead next. This is Grace Lee. I'm Associate Chief Medical Officer for Practice Innovation at Stanford Children's Health, Professor of Pediatrics, Stanford University School of Medicine, and I have no conflicts. Dr. Long.
Yes, good morning, Sarah Long, pediatric infectious disease doctor and professor of pediatrics at Drexel University College of Medicine. I have no conflict.
Thank you. And let me check to see if Dr. Sanchez has been able to join. Okay, we'll move on and come back. Next, we'll move on to the Ex-Officio and Liaison representatives. I will announce the organization name, and then please indicate if you are present and your first and last name. We'll begin with the Centers for Disease Control and Prevention.
Hello, it's Jose Romero, present, NCIRD.
Thank you, Dr. Romero. Good to hear your voice. Next, we'll have Centers for Medicare and Medicaid Services.
Good morning. This is Mary Beth Hance for CMS, present.
Thank you. Food and Drug Administration.
Hi, good morning. This is Doran Fink, representing the U.S. Food and Drug Administration Office of Ed.
Thank you. Health Resources and Services Administration.
Good morning. This is Deborah Hastings representing HRSA.
Thank you. Indian Health Service.
Good morning. This is Dr. Matthew Clark representing Indian Health Services.
Thank you. National Institute of Health.
Yeah, good morning. This is John Bible representing the National Institute.
Morning. Office of Infectious Disease and HIV/AIDS Policy.
Good morning. This is David Kim, OIDC in the Office of the Assistant Secretary for Health. Thank you.
Morning, and thank you. We'll move on to our liaison representatives. American Academy of Family Physicians.
This is Pamela Rockwell. Good morning. Sorry about that. AAFP, Professor of Family Medicine, University of Michigan Medical School.
Thank you. American Academy of Pediatrics.
Good morning. This is Mark Sawyer. Today I'm representing the American Academy of Pediatrics and the Pediatric Infectious Disease Society.
Oh, thank you, Dr. Sawyer, wearing multiple hats today. And do we have American Academy of Pediatrics Thread Book? Are you also representing them today?
I think I am. Yes.
Thank you, Dr. Sawyer. American College Health Association.
Good morning. This is Sharon McMullen and Dr. Tavi Chai for ACHA.
Thank you. American College of Nurse Midwives.
Carol Hayes, present.
Thank you. American College of Obstetricians and Gynecologists.
Dr. Linda Eckert, University of Washington, representing ACOG, present.
Thank you. American College of Physicians.
Good morning, Dr. Jason Goldman, General Internal Medicine, Coral Springs, Florida, affiliate assistant professor at Florida Atlantic University, representing American College of Physicians. Pleasure to be here.
Thank you. American Geriatric Society.
Dr. Ken Schmader for AGS.
Thank you. America's Health Insurance Plans.
Yeah, this is Bob Gluckman here for ACIP. Thank you.
Thank you. American Immunization Registry Association.
Good morning. This is Elizabeth Perilla here for ERA.
Thank you. American Medical Association.
Sandra Freihofer, General Internal Medicine Physician in Atlanta, Adjunct Associate Professor of Medicine at Emory University School of Medicine, representing the American Medical Association.
Thank you. American Nurses Association.
Chad Riddle, representing the ANA.
Thank you. American Osteopathic Association.
Good morning. Stan Growler, representing the AOA.
Good morning. American Pharmacists Association.
Good morning. This is Michael Hogue, Dean and Professor of Pharmacy at Loma Linda University in California, representing the American Pharmacists Association.
Morning, and thank you. Association of Immunization Managers.
Good morning. Heather Rose for AIM, present.
Thank you. Association for Prevention, Teaching, and Research.
Good morning. Christy Moline Jeffel, Assistant Professor, Department of Family Medicine, University of Pittsburgh, representing APTR.
Thank you. Association of State and Territorial Health Officials.
Good morning. This is Nirav Shah. I'm the Director of the State of Maine Center for Disease Control and Prevention, and I am the President of ASTO. Thank you.
Thank you. Biotechnology Innovation Organization.
Good morning. Phyllis Arthur, representing Bio.
Good morning. Council of State and Territorial Epidemiologists.
Christine Hahn, present.
Thank you. Canadian National Advisory Committee on Immunization.
Good morning. Shelley Deeks, Chair of NACI, present. Thank you.
Thank you. Infectious Disease Society of America.
Good morning. Jeff Duchin, Health Officer for Public Health, Seattle and King County, and Professor of Medicine, Division of Infectious Diseases, University of Washington, Seattle.
Thank you. National Association of County and City Health Officials.
Good morning. This is Matt Zahn, representing NACHO.
Thank you. National Association of Pediatric Nurse Practitioners.
Good morning. Patsy Stinchfield, representing NAPNAP, present.
Good morning. National Foundation for Infectious Diseases.
Good morning. This is Dr. Bill Schaffner, Professor of Preventive Medicine and Infectious Diseases at Vanderbilt and the Medical Director of the National Foundation for Infectious Diseases.
Thank you. National Medical Association.
Good morning. Pat Whitley Williams, Pediatric Infectious Diseases, Rutgers Robert Wood Johnson Medical School in New Jersey, representing National Medical Association.
Thank you. Pharmaceutical Research and Manufacturers of America.
Good morning. Corey Robertson, present.
Morning, and thanks. Society for Adolescent Health and Medicine.
Good morning. It's Amy Middleman, representing SAM.
Thank you. I believe there are a few additional members who will be joining later. I'd like to go back to our ACIP members and ask if Dr. Sanchez could state his name, his affiliation, and any conflicts of interest. Dr. Sanchez?
Morning. Good morning, Grace. Pablo Sanchez, I'm Professor of Pediatrics at the Ohio State University College of Medicine and at Nationwide Children's. I'm a neonatologist and pediatric infectious disease specialist. I have no conflict of interest. Thank you.
Thank you. And are there any additional liaison representatives who have joined who have not had the opportunity to call on yet?
Hello, Evan Anderson, physician at Emory University.
and I am actually representing PIDS today.
Well, thank you, Dr. Anderson, and welcome. So for our committee today, we do have a quorum and we're able to proceed. And before we start, Dr. Wharton, do we have any announcements this morning?
Dr. Fink, would you be able to provide a brief update on recent regulatory actions by the Food and Drug Administration?
Certainly, I can do that. So, of course, the reason why we're gathered here this morning is because yesterday, FDA authorized under our emergency use authorization authority 2 modified mRNA COVID-19 vaccines formulated to have bivalent strain compositions. One vaccine is manufactured by Pfizer and BioNTech and has been authorized for use as a booster dose in individuals 12 years of age and older who are at least 2 months removed from completion of their COVID-19 vaccine primary series or at least 2 months removed from their most recent booster dose with a monovalent, i.e. Originally authorized COVID-19 vaccine. The other bivalent vaccine that we authorized is manufactured by Moderna, and it is authorized for use in individuals 18 years of age and older, again, who are at least 2 months removed from either completion of their primary series or their most recent booster dose with a monovalent or originally authorized COVID-19 vaccine. Each of these bivalent vaccines contains a component for the original ancestral SARS-CoV-2 strain that was the basis for the originally authorized COVID-19 mRNA vaccines. And additionally, each of these vaccines contains a component for the Omicron Ba4, Ba5 sublineage. These bivalent vaccines will replace use of the original monovalent vaccines as booster doses in the populations who are eligible to receive them. So therefore, individuals 12 years of age and older who will be boosted with the Pfizer vaccine will now receive the bivalent. The original monovalent is no longer authorized for that population. And likewise for Moderna, for individuals 18 years of age and older. FDA authorized these bivalent vaccines with the goal of improving protection afforded by vaccine booster doses by having the vaccine strain composition more closely matched to the currently circulating SARS-CoV-2 strains, the vast majority of which in the US are now Ba5, and additionally by retaining the original strain component for which we have so much experience with these vaccines being safe and effective. FDA in its authorization considered a totality of evidence that consisted primarily of an extrapolation approach based on data from clinical trials with similar bivalent vaccine formulations consisting of original and Omicron BA1 sublineage components, as well as extensive experience with the use of the original monovalent vaccines as both primary series and booster doses. All of these data represent data collected with human experience. Additionally, FDA considered supportive data from some animal studies that provided additional reassurance about our extrapolation approach. FDA encourages everyone who is eligible for these bivalent booster vaccines to get them, to improve their protection against SARS-CoV-2, disease caused by SARS-CoV-2, including serious consequences of COVID-19, such as long COVID. And especially, we would encourage individuals who have been waiting to get their booster dose, or individuals who are far out from their last booster dose, to take advantage of the authorizations of these bivalent vaccines as we head into the fall and winter months, where modeling is predicted that COVID-19 disease activity will increase. Thank you very much.
Thank you very much, Dr. Fink, and thank you for your work as always at the U.S. Food and Drug Administration. We will now move on to the first session for the.
Dr.
Yes?
This is Dr. Wharton. I'd like to make a brief additional comment.
Oh, sure. Thank you, Dr. Wharton.
So with FDA's regulatory action approving the updated bivalent booster yesterday, we have an opportunity to update and simplify our recommendations for vaccine use. We hope this is the start of moving toward a more usual type of vaccine recommendations and process, as well as a more normal cadence of ACIP meetings. This will be a transition, though, and I'm sure there'll be some bumps in the road, but it's an important move towards simpler recommendations, as well as an updated vaccine that we expect to provide broader protection. We thank the committee for their ongoing support. Thank you, Dr. Lee.
Thank you very much, Dr. Wharton, and thanks for setting the stage. I really appreciate it. I do want to echo Dr. Wharton's comments that we are hopeful that as we move into this next phase of the pandemic, that we also can move into the next phase of ACIP meeting schedule. So we are hopeful that after today's discussion, we'll have clarity on that. We'll move on to the first session for today. Dr. Matt Daly, chair of the COVID-19 Vaccines Work Group, will provide our introduction and overview of today's session. Dr. Daly.
Good morning, everyone. So I'm going to introduce today's session on behalf of the ACIP COVID-19 Vaccines Work Group. That's fine. Yeah, next slide's fine. Thanks. An important point that I wanted to highlight to start out with was the global impact of the first year of COVID-19 vaccinations. And this is based on mathematical modeling of transmission and infection in 185 countries, December 2020 through December 2021. And based on this modeling, COVID-19 vaccinations are estimated to have prevented somewhere between 13.7 and 15.9 million deaths globally. And this represents an estimated 63% reduction in total COVID-19 deaths globally, again, from the same modeling. Next slide, please. So I also wanted to provide a little, or we also wanted to provide a little bit of an update here, just to remind the audience that Novavax COVID-19 vaccine is a protein subunit vaccine platform, and this has been authorized for emergency use. So Novavax COVID-19 vaccine is now recommended as a 2-dose primary series for people ages 12 and older in the United States, and 670,000 doses of this vaccine have been distributed across all U.S. states and territories. A total of 3.2 million doses have been purchased by the U.S. government, and then as of last week, 14,000 doses have been administered, including 2,591 individuals who've received the full 2-dose primary series. Next slide, please. So on this slide, and I realize it's a busy slide, I apologize for that, but this is reviewing the ACIP COVID-19 Vaccines Work Group work during the month of August. So in the work group, we have reviewed extensive data regarding bivalent boosters and the broader context in which bivalent boosters are authorized and that we're discussing today. This includes data from multiple clinical trials of bivalent boosters, including those with an Omicron component, which have demonstrated safety and immunogenicity in more than 1,700 adults. And this includes adults with and without prior SARS-CoV-2 infection. And as referred to by Dr. Fink, this includes data for more than 1,400 individuals who received a bivalent vaccine with an Omicron component specifically. In addition, in workgroup activities, we've reviewed anagenic cartography, and we will explain that concept later this morning, but anagenic cartography and immunologic implications of SARS-CoV-2 variants. again, setting the context for bivalent vaccines. And then in addition, we've reviewed modeling data looking at pandemic outcomes in various scenarios, including potential impact of new variants, and then also the timing of booster vaccination programs and estimated vaccination coverage with a booster. In addition, we've reviewed extensive data regarding rare events of myocarditis after COVID-19 vaccination. In addition, we've reviewed epidemiology of COVID-19 disease and variants, including the currently dominant Omicron Ba4/5 variant. And then through all this, we've engaged in broad discussions regarding the use of bivalent boosters in people of all ages currently recommended to receive a booster. Next slide, please. So the agenda for today is as follows. First, we're going to hear from Dr. Scobie from the CDC, who's going to review epidemiology of COVID-19 and SARS-CoV-2 variants. Then we'll hear from Dr. Thornburg from the CDC, who will review immunology of SARS-CoV-2 variants. Next, we'll hear from Dr. Link Gellis, who will provide updates to COVID-19 vaccine effectiveness. After that, we'll hear from Dr. Shimabukuro, who will provide updates on COVID-19 vaccine safety. We'll then have a break followed by public comment. Next slide, please. After that, we'll hear from Dr. Das from Moderna, who will present their data regarding the Moderna bivalent COVID-19 vaccine. After that, we'll hear from Dr. Gruber from Pfizer, who will review Pfizer-BioNTech bivalent COVID-19 vaccine. And then we will have discussion followed by a break. And then after the break, we'll hear from Dr. Oliver from the CDC, who will discuss and present the evidence to recommendations framework for the use of bivalent COVID-19 booster doses. Following this, we'll hear from Dr. Hall and Dr. Twentyman from the CDC, who will present clinical considerations updates in the context of the newly authorized bivalent booster doses. Following this, we'll have a discussion and then a vote, and the votes will be separate votes for the use of Moderna COVID-19 vaccine bivalent in individuals ages 18 years and older, and Pfizer-BioNTech COVID-19 vaccine bivalent in individuals 12 years and older. Next slide, please. So I'd like to sincerely thank the COVID-19 vaccines work group members, including ACIP members, Ex-Officio and government members, liaisons, consultants, and the outstanding leadership of Dr. Sarah Oliver and Dr. Evelyn Twentyman. Next slide, please. As well as a long list of CDC participants who make all of this work happen. Thanks to them as well. Next slide, please. And this concludes my introductory comments. Back to you, Dr. Lee.
Thank you so much, Dr. Daly. We'll move directly on to Dr. Heather Scobie from CDC, who will provide an update on the variants and epidemiology of COVID-19.
Good morning. Next slide. Next slide. The Omicron variant has 5 main sublineages, numbered BA1 through BA5, which are further divided into hundreds of daughter sublineages. Omicron has been shown to have increased transmissibility but decreased severity relative to previous lineages. Omicron has many mutations in the spike gene, as shown in the picture on the right, that are associated with lower vaccine effectiveness and reduced efficacy of some monoclonal antibody treatments. Next slide. This stacked bar graph shows recent U.S. trends in the national weighted estimates of variant proportions and nowcast projections of circulating SARS-CoV-2 lineages by week of specimen collection. Omicron sublineages, depicted in different purple, pink, and teal shades, have been over 99% predominant for many months now. The BA2 sublineage in lavender and BA2.12.1 sublineage in pink have been displaced by the BA4 and BA5 sublineages in the teal and blue shades. For the week ending August 27th, BA5 in dark teal comprised 88.7% of sequences, BA4.6 in blue comprised 7.5%, and BA4 in light teal comprised 3.6%. Next slide. These are estimated numbers of reported COVID-19 cases by variant based on the variant proportions, scaled by the number of nucleic acid amplification tests, or NATs, including PCR tests, which are the sampling frame for genomic sequence surveillance. The trends highlight that the more recent waves caused by the BA2 Omicron sublineages in pink and lavender and the BA4 and 5 sublineages in teal and blue have been much smaller than the initial Omicron wave related to the BA1 sublineages in darker purple colors. Next slide. This map shows the relative proportions of the Omicron sublineages across the 10 Health and Human Services regions. BA5 in teal represented the majority of circulating lineages in all regions during the most recent week. Next slide. Next slide. This graph shows the trends in the daily numbers of COVID-19 cases reported in the US since the beginning of the pandemic. The number of cases associated with the Alpha variant was relatively small compared to the Delta and Omicron variants. Nationally reported cases started increasing in April, leveled off in June and July, and have been decreasing in August. As of August 30th, there have been over 94 million reported COVID-19 cases in the US. Next slide. This graph shows the daily number of reported COVID-19 cases overlaid with a 7-day moving average of NAT % positivity, which is a marker of transmission intensity. The trends align remarkably well in late 2020 through early 2022, but starting in May, the trends become uncoupled, with numbers of reported COVID-19 cases leveling off, while NAT positivity in late July increased to a high of 20%, related to increased transmission, decreased provider-based testing, and increased at-home testing, which is largely unreported and results in an underestimation of reported cases. However, NAT positivity and case counts have decreased during August, suggesting a decrease in overall transmission. Next slide. These are the weekly trends in the rates of COVID-19 associated hospitalizations by age group from COVIDNet. Higher hospitalization rates have always occurred in the 65+ year age group in red, followed by people ages 50 to 64 years in purple, and 18 to 49 years in blue. On the right, you can see that since April, hospitalization rates have increased more in the 65+ year age group compared to those among younger adults, which did not see large increases in hospitalization rates. Next slide. These are data from an MNWR published last Friday. The graph shows hospitalization rate ratios by age group compared with ages 18 to 49 years. The different color bars relate to different time periods through May 31st, with Delta in gray, Omicron BA1 in light blue, and Omicron BA2 in dark blue. Over time, there is a widening gap between hospitalization rates in older and younger adults, and age remains a strong risk factor for COVID-19 illness severity. Next slide. These data from the same MMWR show that the median age of patients with COVID-19 associated hospitalization increased across the 3 periods, while the percentage of hospitalizations that were likely COVID-19 related decreased slightly between the Delta and Omicron periods. The percentage of cases with underlying conditions, immunosuppression, and residing in long-term care facilities increased, while outcomes related to clinical severity decreased. These trends are likely related to a combination of increasing vaccination, waning immunity, and changes in COVID-19 treatments and differences in variant severity over time. Next slide. This graph shows a 3-week moving average of age-adjusted rates of COVID-19 associated hospitalizations by race and ethnicity. Throughout the pandemic, American Indian and Alaskan Native people, shown in light blue, Black people, shown in navy blue, and Hispanic people, shown in red, have been disproportionately affected by COVID-19 associated hospitalizations compared with white and Asian Pacific Islander people, shown in green and gray, respectively. The scale of these disparities has decreased after the Omicron surge, but hospitalization rates are still highest among American Indian, Alaskan Native, and Black persons. Next slide. This graph shows the U.S. trends in the daily number of provisional COVID-19 deaths reported to the National Vital Statistics System since the start of the pandemic. Nvss data come from death certificates and are generally considered to be more reliable than the death data reported through COVID-19 surveillance. As of August 27th, there have been over 1,042,000 deaths due to COVID-19, reported cumulatively in the U.S. Omicron has caused a sizable number of deaths despite decreased relative severity because of high case numbers. Next slide. These are the weekly trends in COVID-19 associated mortality rates from Nvss by age group. The data show that higher mortality rates are consistently observed in older age groups, most notably on this graph, among those aged 75 plus, 65 to 74, and 50 to 64 years, as shown in the brown and pink colors. Similar to hospitalizations, we have observed a recent increase in death rates for older ages, especially for ages 75 plus years. Next slide. These are the weekly trends in age-adjusted COVID-19 associated mortality rates from Nvss by race and ethnicity. These data show that higher mortality rates have been observed throughout the pandemic among Black people, shown in navy blue, American Indian and Alaskan Native people in light blue, and Hispanic people in red, compared with white people shown in green. Next slide. Since April, there has been less evidence of disparities in mortality rates by race and ethnicity, but mortality rates were low overall relative to earlier in the pandemic. Next slide. Next slide. As of August 24th, almost 224 million people in the US have been vaccinated with a primary series, which is 72% of people ages 5 years and older, while 49% have received a first booster dose, and 34% of people ages 50 years and older have received a second booster dose. Despite progress, there are still important differences in primary series vaccination coverage by age and booster dose coverage by race and ethnicity and disability status. Next slide. This slide shows adjusted rates of COVID-19 cases by vaccination status. Though case rates in people with a primary series increased during waves associated with the Delta and Omicron variants, case rates for unvaccinated people have always exceeded those for vaccinated people. In July, unvaccinated people ages 5 years and older had 2.4 times higher risk of testing positive for COVID-19 compared to people vaccinated with at least a primary series. Next slide. This graph shows age-adjusted rates of COVID-19 associated hospitalizations by vaccination status and receipt of a booster dose. Hospitalizations for COVID-19 have been consistently higher among unvaccinated than vaccinated people over time. In June, unvaccinated adults ages 18 years and older had 4.6 times higher risk of COVID-19 associated hospitalization compared to those vaccinated with a primary series and at least one booster dose. Next slide. This slide shows age-adjusted rates of COVID-19 associated deaths by vaccination status and receipt of booster doses. In July, unvaccinated people ages 5 years and older had 8 times the risk of dying from COVID-19 compared to people vaccinated with a primary series and at least one booster dose. This represented a decrease in the rate ratio from earlier in the year, possibly related to waning immunity and increased community transmission of the Omicron sublineages, as well as other factors. Next slide. In data from July 2022, people ages 50 years and older with a second booster dose had 14 times lower risk of dying from COVID-19 compared to unvaccinated people the same age, and 3 times lower risk of dying from COVID-19 than people the same age with one booster dose. These data suggest that getting a second COVID-19 vaccine booster dose can enhance protection that might have decreased over time after receiving the last dose. Next slide. Unvaccinated people are at much higher risk of severe COVID-19 illness than vaccinated people. Most vaccinated people who get severe COVID-19 illness have multiple risk factors, including older age and underlying medical conditions like immunosuppression, diabetes, and chronic kidney, lung, cardiovascular, or neurologic diseases. Antiviral drugs can help reduce the risk of severe illness in people at higher risk. Next slide. In summary, CDC continues to monitor emerging variants like the sublineages of Omicron, including their prevalence and impact on disease incidence and severity over time. Racial and ethnic minority groups have been disproportionately affected by COVID-19 associated hospitalization and mortality. These inequities have decreased over time but have not been eliminated. Recent trends show evidence of increasing severe illness, including hospitalization and death in people of older age and people with underlying health conditions. Current vaccines offer protection against severe COVID-19 illness and death, so it's important to stay up to date with vaccination, including receipt of all booster doses in eligible populations. Therapeutics and multiple prevention measures should be used to protect people at higher risk of severe COVID-19 illness, regardless of vaccination status. Next slide. I'd like to thank the following individuals. Thank you.
Thank you very much, Dr. Scobie. This presentation is now open for questions. Dr. Paling.
All right, good morning. And Dr. Scobie, thank you for a great presentation highlighting the importance of what is going on and the impact that COVID-19 has been having on our populations. And I very much appreciated the data showing that the hospitalization rates are increasing, particularly for those over 65 years of age. One of the comments that's commonly said is that COVID is more severe in adults than children. And I think it's important to highlight that deaths are more common in adults than children, and hospitalizations are more common in adults than children. And so do we have any data, since we're focusing on 12 and older, on the comparison of the hospitalization rates compared to the baseline rates of hospitalization across age groups? Thank you.
So you're interested in whether hospitalization rates are increasing in children despite the fact that they're low compared to adults?
Yes. Are they yes, because we know that the hospitalization rates in children are lower than adults baseline. And so are they increasing because of COVID? So how is the COVID hospitalization rates compared to their baseline rates for each of the age groups is what I'm asking. Thank you.
So you're talking about with and without, like before COVID compared to the period of COVID, the COVID pandemic?
Exactly. So trying to get to the fact that, because we constantly have children that are hospitalized with COVID all the time. And so this is not, from my perspective, this is not a benign disease in children. And so I'm trying to see if we can visualize this impact. Thank you.
Okay. I think that the comparison of like non-COVID baseline to COVID baseline is probably harder to visualize on the using the data that's available on COVID data tracker. But I do believe that during times of increased case incidence, that all age groups do increase. The trends that I was talking about is that at this point, sort of the relative increase is currently higher in those older age groups that I was talking about. But if we kind of take them out of the picture, I'm just looking at it now, I believe it's true that rates, increase in all age groups. It's just a matter of scale, if that makes sense. So
that makes
I'm looking,
sense.
Yeah.
And that's helpful. So they're increasing for all age groups, and that's a really important point. Thank you.
Yes. Thanks.
Thank you. Dr. Brooks?
Thank you very much for that excellent presentation. I think it's really important to frame the situation as we are here September 1st. Just two comments. One, I'm encouraged by the reduction in the disparities of African Americans and Alaskan Natives. When you show some data on case rates, hospitalization rates, death rates, it's still there, but it is diminishing. I think a lot of that is the effort of the CDC and others to get out messaging that is targeted to these communities. And the immunization rates, the vaccination rates have pretty much leveled off in terms of the disparities. The other thing, I think a very important fact as we discuss boosters today is the fact that 8 times higher death rate versus unvaccinated with a booster, but 14 times the death rate with 2 boosters. So I just want to note that it underscores the importance of continuing to get boosted, as I think some of the population may get COVID vaccine weary and just determined that they're okay with primary 1 booster. So thank you for the information and manner in which you framed it.
Thank you, Dr. Brooks. Dr. Daly.
Yeah, thanks so much, Dr. Scobie. Could you go back to the slide that showed hospitalization rates by age? Because I found that striking and I wanted to ask a clarifying question. I think it's maybe 10 or 11 or 12, something like that.
I think it's 10. Yeah.
Okay, so, and I bring this up in the context of timing of a fall bivalent booster in the elderly. So it looks like certainly we're in the middle of a spike in hospitalization in the elderly, and this is 65 and over, and then this is sort of irregardless of vaccination status. Is that correct?
That's right.
Okay.
The bi-vaccination status was from the same COVID-net system was shown later in the slide deck.
Yeah, okay. And so then this is a mix of, fully vaccinated and including with boosters, plus some who have just 1 or 2 boosters and some who just have primary series. Okay, great. Thanks so much for, thank you for showing that and for clarifying.
Thank you. Dr. Duchin?
Thank you, and good morning. These data clearly show the importance of booster doses in preventing severe disease, particularly among older adults and those with underlying health conditions. I'm wondering if you can tell us a little bit about how CDC is thinking about measuring the impact of post-acute sequelae or long COVID and the potential benefit of vaccination in that context. Thank you.
So there are ongoing efforts to complete, it's not something that's really assessed through ongoing surveillance because of the difficulty of collecting the data systematically, but there are plans or ongoing repeated surveys that will be implemented to assess that. In terms of vaccine effectiveness against long COVID, I think that would be a question for Dr. Linkelis. Is she on the line?
Hi, this is Dr. Lincoln.
Oh, great. Thank you.
Yeah, I can answer the question about VE for post-COVID conditions. I mean, generally, I think the research has been a little bit mixed and inconclusive, although there is some benefit clearly for prevention of initial infection close to vaccination, especially close to booster vaccination, as well as prevention of severe disease, which has been associated with higher likelihood of long COVID. I think the lack of a standard definition globally and ability to kind of track patients longer term, as well as diagnostic testing for long COVID, has complicated the ability to measure VE, but it has remained a research priority. Thanks.
Thank you so much. Do you think it would be possible, perhaps at a future meeting, to have a summary of what information is available on this topic?
Yes, I'm sure we could do that.
Thank you so much.
Thank you. Dr. Sanchez?
Yes, thank you for that. I just had a question. Have you been able to analyze similar data in pregnant women to see the effect of the not just the primary series, but also the boosting on COVID hospitalizations and mortality?
So it may be that COVIDnet is able to do that, but I don't have that information. We don't collect any information on pregnancy status as part of the vaccine impact surveillance data that I presented, which are the cases and deaths by vaccination status. I could, along with the other request that was made, I could pass that one to colleagues and ACIP Secretariat could consider that maybe that could be included in the future.
No, thank you. I think it's important because it's something that we, that as another point in terms of encouraging vaccination among pregnant women, and also I also think that it'd be important to capture data, and I know this is a little bit separate from the vaccination, but even on the use of the monoclonals and outcomes during pregnancy. Thank you.
And Dr. Sanchez, this is Dr. Fleming-Dutra. Thank you so much for that question and comment. I just wanted to point out that we are hoping to address vaccine effectiveness and these questions about COVID vaccine use in pregnant women and effectiveness in pregnant women and their infants at a future ACIP meeting.
Great, thank you.
Thank you. And I don't see any other hands raised. I do have one last question / request for the group, which is, I wanted to do, well, two things. One is I wanted to emphasize Dr. Peeling's point. We know that the mortality rates compared to older adults is lower in children, but when we look at leading causes of death in children, for the young kids, it's the 4th to 5th leading cause of death in kids. And so the point she makes about what is the burden on severe disease / hospitalization, I think is similar to what we see with all-cause mortality, and wanting to make sure that we really understand the burden and can articulate that well, particularly in pediatric practices. So that would be extremely helpful. The other, question I have is really around the commentary around severity, which it certainly does feel different, despite it being more prevalent in the Omicron era compared to Alpha and Delta. But I wanted to ask if there are any studies that actually compare unvaccinated and potentially uninfected, if we have that information, people in terms of severity during Omicron to those who were unvaccinated in Alpha or Delta. Since we see those graphs between the vaccinated and unvaccinated are so different, or the hospitalization rates. And I ask that because there is a perception that it's less severe, we don't have to worry about it as much. But I think this is, the Omicron wave is on the background of people who have both had infection and vaccination. So we are very different from an immune perspective as a population than we were during the Alpha wave and the Delta wave. So I wanted to ask, has there been any work on that? Is it possible to take a look at your data to tease that out, to really understand the severity comment?
So, Dr. Lee, are you asking when you control for previous infection, vaccination, is Omicron really less severe than previous variants? Is that the question?
Yes, because if you look on slide 11, actually, what I see is, is it slide 11? Oh, maybe it's slide 12 or 10. I can't remember which one. But the point being that because it includes, I think that's it. So, this includes 18 and older. And so I definitely see in terms of the outcomes, it looks like there is shorter lengths of stay, less mechanical ventilation, fewer in-hospital deaths. But it's not clear to me, what proportion of that population in the Omicron era has been vaccinated and previously infected compared to the Delta era. And for me, it would be really helpful to know if the severity was attenuated by cumulative immunity, or if it was attenuated because of Omicron in and of itself. And I think, it feels to me like I haven't really understood how well we've teased that out. And I hear a lot of comments that Omicron is less severe, but I'm not so sure that's the case. I feel like it's a very different population now than it was during Delta.
Yeah, you're absolutely right that these results that we're showing here are actually just descriptive results that don't adjust for the impacts of vaccination. And so, they have to be interpreted in that light. But although this study doesn't address your point, there are a number of publications that do that type of analysis that take into account immunity status and have shown that Omicron is less severe than Delta, the previous variant. So I I think we're firm in that fact. The issue is that there are so many more Omicron infections because of increased transmissibility that it's not, the reduced severity of Omicron is not something maybe to take lightly, because with a higher chance of getting the disease, there will still continue to be quite a large number of hospitalizations and deaths. And I tried to allude to that fact on several of the slides, but I think it's good to make that point clear. Does that help?
Yes, that does. Yeah, the cumulative burden or the attributable risk is substantial for Omicron. Thank you. Dr. Sanchez, one last question, and then we'll move on to the next section.
Sure, thank you. You know, as I look at these data, particularly slides 22 and the following one, 23, I guess, it's just, you know, there's a lot of issues raised, including with me and even people who I counsel and people who ask me about booster dosing. And, you know, given that that the high seroprevalence of people who've had COVID already now in June 2022, so this would be data on very high seroprevalence in, you know, among the general population, but it really attests to the need for booster dosing. I think that it really speaks for the fact that we need to be recommending it. And I just wanted to comment on that because, you know, there's been a lot as to whether we should get that booster or should we wait for the fall, and I guess for today. But it really does point that even in the era where there's high natural infection, that presumably then the booster dosing has also contributed to the decrease in hospitalization and mortality. But just want to comment. Thank you.
Thank you, Dr. Sanchez. We will move on next to the next speaker, which is Dr. Natalie Thornburg, who will speak about the immunology of SARS-CoV-2 variants. Dr. Thornburg.
Great, thanks. So today I will be talking about the immunology of Omicron variants, but I'm going to specifically focus on a technique that laboratorians are using to estimate how different viruses are from each other, that it can inform vaccine selection. So I'm going to talk about anagenic cartography. And this method, lineage numbers aren't necessarily reflective of how distant viruses are from ancestral viruses. So it doesn't necessarily, Ba5 isn't necessarily more distant from the vaccine strain than Ba2, Ba3, just because of the number. And we're accustomed to looking at virus lineages and viral variances in phylogenetic trees, and those are generated according to genetic differences and not anagenic differences. And that's not how your immune system sees viruses. It sees viruses as shapes. Antibodies see the shape of a spike protein and not the linear sequence of nucleotides or amino acids. So anagenic cartography is a method to measure how viruses might look to antibodies after vaccination or infections. So what is anagenic cartography? It's a visualization method used to determine how closely related different viruses are, but not in the context of genetics or amino acid sequence, but anagenically. And it uses a matrix algorithm called matrix completion multiple dimensional scaling algorithm to generate a map. It was originally developed for H3N2 influenza viruses using hemagglutination inhibition titers. And you can generate either two-dimensional or three-dimensional maps to see how closely related viruses are. Next slide, please. All right, so this is just a summary of how an anagenic map or anagenic cartography might be done. So you take a matrix of viruses in sera and do neutralization assays, and you create a checkerboard of the results from these neutralization assays. Now, the method of cartography is not limited by the kind of sera that one is using, and it's not limited by the neutralization technique that one is using. What's important in this method is that you know the information about the material being used in the assay, so that you know the history of the sera that's being used, and you know the sequence of the viruses being used. And in this cartoon, they're demonstrating that they have, in this particular study, have taken hamsters and inoculated them with different viruses with known sequences, and then collected serum, day 7, day 26, from those hamsters, so they have antibodies raised against specific viruses. And then they are showing 2 different neutralization assays that could be used. Pseudovirus neutralization assays, which are on the shell of a different virus with just the spike protein from SARS-CoV-2 with a known sequence, or an authentic virus, so a virus that's been isolated from a respiratory specimen from an infected person. And then you do neutralization assays and generate a matrix of neutralization titers, and that's shown in the square with the red and the yellow and the green. So for every individual virus, you have a neutralization titer against a specific serum, and then you use that to create the map. Next slide, please. So you use the titers that you generated from doing neutralization assays of those different hamster serum in that previous cartoon. Use those titers to create a distance map. So you might, and that's in the top right-hand corner, you might log transform your neutralization titers and then use that to generate a matrix, a distance matrix. So each square might represent a different, like a change in titer. And each different assays that one might use, the squares might represent different distances. A lot of the maps that are being generated right now for coronaviruses, each square is a 2-fold difference change in neutralization titers. And then you take those table distance and you generate the map that's shown on the left. And you might say, so you can color code the viruses, and you can put the squares. Most publications have been using empty squares for sera and filled circles as viruses to see how closely related they are. There's advantages and disadvantages to this method. The advantages include that it's extremely easy to interpret because you can just look and see that in this case, antigen BE is pretty far from antigen LE, but BN and LE are pretty closely related. And it's fairly accurate, and it gives you a really good overview rather than just looking at sequence alignments, which can get complex. And it gives you quantification and can give you predictions about how easily a virus might escape an antibody response. There are some drawbacks. It can be an oversimplification. There can be bias in the maps, assay bias. Say, for example, a map generated with pseudovirus neutralizations might look different than a map generated with authentic virus neutralization or animal sera versus human sera. There can be effects of outliers, and there is always map uncertainty. The dots are not actually quite as finite as they might not look in a map. There is some uncertainty. Next slide, please. Okay, so what do we know about how anagenically similar Omicrons are from earlier viruses and how anagenically related they are to each other? This is just a reminder of the Omicron lineages and sublineages and the amino acid variations that have been observed in the spike protein. This is not the full spike protein. This is just a few regions in some areas where there are variations between Omicron lineages. The N-terminal domain is shown in a blue square, and the receptor binding domain, which is where most of the potent neutralizing antibodies would be binding the receptor binding domain and blocking ACE2 binding, and then downstream of the receptor binding domain is shown at the bottom. Next slide, please. These are just some of the amino acid differences projected onto the structure of the receptor binding domain. Ba4, Ba5 is shown on left. The unique amino acids to Ba4, Ba5 are shown in B on the left in red. And then the different variant amino acids on the right are projected onto the ACE2 footprint. So where the spike receptor binding domain binds ACE2. And you can see that there are some common to most of the Omicrons, to BA1, BA2, BA3, but not BA4 and 5 are shown in white. Unique to BA4 and 5, again, are shown in red. Unique to BA2 is shown in magenta. So it's pretty complex. If you were just to look at this, you wouldn't necessarily be able to say which one of these Omicrons is most different from ancestral virus and say that's the one that's most likely to escape vaccine or neutralization. So next I'm going to show you 3 anagenic maps from peer-reviewed publications that include Omicron viruses. 2 of them are 2-dimensional and 1 is 3-dimensional, and only 2 of these maps include BA4, BA5 spike sequences. Next slide, please. All right, so in this one, investigators were able to look at the BA1 and BA2 lineages of Omicron, but not BA4 and BA5, because this was submitted before really the emergence and broad circulation of BA4 and BA5. So in this study, they used convalescent sera from unvaccinated persons to generate anagenic cartography for BA1 and BA2. And so what you see here are squares, again, are sera from convalescent patients. Circles are viruses. The red is delta. Light blue is ancestral viruses. Green alpha, yellow beta. And then Omicron viruses are light pink and dark pink, and they're kind of off there to the right. And so they've shown convalescent sera in the left panels, and then on the right side of the panel, they show vaccinated participants and not convalescent sera, and they see a little bit of difference between just the vaccinated alone versus convalescent sera. The SACO of this is that Omicron viruses are more distantly related from ancestral viruses than the earlier variants, and that you see more dramatic difference when you're looking at individuals who had been vaccinated only as opposed to infected, using infected sera. Next slide. Okay, and this is another study that was published this summer, but this one includes analysis of BA4 and BA5, and this one is also a 3-dimensional map. So it's shown you a front view, a top view, and a side view, and it's a little harder to look at and understand. But this also uses pseudovirus neutralization data. They've used serum from breakthrough BA1 infection. So these participants had been vaccinated and then were infected with Omicron. And then they also have a panel of human monoclonal antibodies that they use to generate these maps. And what this map indicates is that the Omicron viruses sort of cluster together, but consistent with the earlier study, cluster away from ancestral virus. And so they're quite anagenically distinct from ancestral virus, Wuhan virus. And that in this analysis, BA4, BA5 are more distant to Wuhan than other Omicron viruses. And next slide. All right, this is the last published map I'm going to show. So in this study, they've used 21 known monoclonal antibodies and used pseudovirus neutralization. And then they also have neutralization using post-third dose sera. And each square in this one represents a 2-fold change in neutralization. And this map is also a 3-dimensional map, but it's not shown in 3 panels, it's shown in 1 panel, and they've generated that 3D by by showing you the arrows on the bottom, which dimension is which. And so if you look at the black circle is ancestral virus D614G, that's ancestor vaccine strain virus. You can see BA1 viruses are clustered a little bit away from BA2 viruses. BA1 viruses are up there on the top left. BA2 lineage Omicrons are over there on the right in blue, in different colors blue. They have a couple different variations of BA2 lineage viruses. And then BA4, BA5 viruses are up there in the top sort of right-hand corner. This map indicating BA4 and BA5 might be most distantly anagenically related to ancestral virus compared to other Omicron lineage viruses. Next slide. So this is just a slide. I do want to indicate that when we look at these maps, it's easy to think of those circles and those squares as really finite things. But whenever one uses bootstrapping, you can see that there's overlap between Omicron lineages. So bootstrapping is just a statistical method to estimate sampling distribution. And there can be, as I said earlier, individual variation in assays, viruses, and individual sera that are used. So this is a map that I pulled from some aggregated data that was published back in May, so it's a couple months old at this point. But I just wanted to use it to demonstrate that there's quite a bit of overlap in the antigenic maps between the Omicron viruses. So the dark blue is ancestral, and Omicron viruses are showing different shades of pink and red. And they cluster away from ancestral virus. There is some overlap, but still using that aggregated data, either BA1 or BA4 viruses may be kind of further away from ancestral viruses. Next slide. So in conclusion, anagenic cartography is an analysis method to visually represent how anagenically related or distant viruses are to each other. They can be generated either in 2 or 3 dimensions, and that the maps cluster Omicron variants away from ancestral and earlier variants. Initial examinations of Omicron lineages indicate that BA4 and BA5 viruses may be more anagenically distinct than BA1 viruses, but notably all of those published assays were done with pseudovirus neutralization. There are quite a few studies ongoing right now using authentic viruses, and so we expect data to vary some between different studies and between serum panels that are being utilized. And that is all for my presentations. I will take any questions. Thank you.
Thank you, Dr. Thornburg. The presentation is now open for questions. Dr. Lair.
Thank you for this presentation. It's a very interesting way of representing the differences. Just to make sure I understand correctly, the distances you're talking about are basically how many antibodies you're generating from each individual variant, so that the farther away you just have different antibody titers. Is that a fair statement?
The distance is how the change in neutralization titer between 2 different viruses. And so say if the distance is 2-fold difference, if like 1 square is 2-fold difference, if you take the serum from a vaccinated person and you measure it against the vaccine strain, and then one of the Omicrons, if it's 6-fold lower, it might be 3 squares separated.
Okay. Thank you very much.
You're welcome.
Thank you, Dr. Duchin.
Thank you for this great work. There was an article published yesterday in the New England Journal of Medicine from Portugal that found that previous SARS-CoV-2 infection had a protective effect against BA5 infection, and that they found this protection was maximal for previous infection with BA1 or BA2. And I'm wondering if you have any comment on those findings in the human population in the context of your antigenic cartography work.
Yes. So So actual protection is always, that data always sort of trumps any laboratory data that we're generating because it's real world evidence of a protection rather than, this is a very limited view of neutralization of viruses. So this is a laboratory setting, serum collected. So there are limitations to this kind of analysis with certainty. So, you know, in that bootstrapped aggregated data I showed you, it did show you there is overlap between the Omicrons. So it's not terribly surprising there is cross protection between the Omicrons. There are differences between Omicrons, but there aren't 50 differences. There are, you know, 3 amino acid changes or 10 amino acid changes. Now, BA2 is pretty similar to BA4/5. It only has 3 differences in the spike protein. So previous infection with BA2, it doesn't surprise me that you get really good protection with BA to BA4/5. And the same goes for BA1. It's a little bit more distantly, there's more changes when you compare BA1 to BA4 and 5 in comparison to BA2 versus BA4/5. But it's not so dramatically different that I'm surprised that there isn't reasonable cross protection between the Omicrons. And of course, the distance, the time since your last infection matters as well, because it's not just the sequence, it's waning of your neutralizing antibody response in addition to the sequence of the virus that you're being exposed to.
Thank you for those comments.
Thank you. And Dr. Sanchez, and then we'll move on to the next section.
Thank you. Very interesting. I guess I'm related to one of the previous questions and the interpretation. When I look at your slide 7, and you're looking at, and they didn't do the more recent variants of the BA4/5 are not included, but on the right panel there. So this is among vaccinated individuals. So there's quite a distance of that Omicron BA1 from serum, which would explain some of the breakthrough infections, or some interpretation.
Yeah. Yes, you are. There is a more dramatic distance between BA1 and the earlier variants in the vaccinated only versus previously infected era. Yes.
Thank you.
Thank you. And let's please move on. Thank you, Dr. Thornburg, for your presentation. It was excellent as always. We'll move on to Dr. Link-Ellis, updates to COVID-19 vaccine effectiveness in the United States.
Hi, good morning. So I'll be giving an update today on Omicron vaccine effectiveness in children and adults. Next slide. As with previous presentations, I've organized the presentation by increasing severity of the outcome, starting with infection, then emergency department and urgent care visits, and then hospitalizations. Next slide. So starting with infection, next slide. I'll start with the Increasing Community Access to Testing, or ICAT platform, which is national community-based drive-through testing data from pharmacies. This platform relies on self-reported vaccine history and uses a test-negative design where cases are persons with at least one COVID-like symptom and a positive NAT test, and controls are symptomatic with a negative NAT test. Models are adjusted for the variables. Shown here. Analyses today focused on the BA4/5 predominant period during July 2nd through August 20th, 2022. Next slide. Here we see relative VE for 3 versus 2 doses against symptomatic infection by age group, with VE estimates in the solid lines and 95% CIs by age group in the dotted lines. Estimates for individual age groups are less important here than the overall trend, which is the same across age groups. We have less follow-up time for the 5 to 11-year-olds due to the booster recommendation being more recent. However, so far the trend is the same as for older age groups. As a reminder, we've seen previously that the primary series VE against infection wanes to 0 within a few months, so these results should be taken in that context. Next slide. Here we have VE of 3 versus 0 doses against symptomatic infection on the left, and relative VE for 4 versus 3 doses on the right, with 50 to 64-year-olds in blue and 65 and older in orange. As with younger age groups, we see waning at or close to 0 VE within a few months of 3 doses, with potentially less waning of the 4th dose, although we have limited follow-up time given when the recommendation was made. Next slide. Moving on to urgent care and emergency department visits. Next slide. The Vision Network is a multi-state network based on electronic healthcare records. Like ICAT, it uses a test-negative design with cases having CLI and a positive PCR and controls having CLI with a negative PCR. VE is adjusted for propensity to be vaccinated weights, calendar time, region, local virus circulation, and age, and vaccination is determined via healthcare records and state and city registries. Next slide. This slide shows VE during Omicron for 5 to 11-year-olds on the top and 12 to 15-year-olds on the bottom by time since last dose. 2-dose estimates are in green and 3-dose in blue. We see similar patterns here across age groups with VE of 2 doses against ED and UC visits waning substantially. In 12 to 15-year-olds, we see a nice bump in VE with a 3rd dose, but did not have enough 5 to 11-year-olds with booster doses to provide an estimate in that age group. Next slide. Now moving on to adult VE during BA2 on the top and BA4 and 5 on the bottom with the same colors as before, 2 doses in green, 3 doses in blue, and now 4 doses in black, which is estimated only amongst those 50 years and up. We see similar patterns in the 2 time periods with waning by time since the most recent dose. During BA4 and 5, when we have more data on the 4th dose available, it appears that the 4th dose wanes somewhat more slowly compared to 2 and 3 doses. Next slide. Now moving on to a new VE platform, which has not been previously shared with ACIP. Cosmos is an opt-in database of more than 162 million patient records drawn from healthcare organizations using the EPIC electronic healthcare records platform. Like other platforms presented, this is a test-negative design focused on the Omicron BA2 and BA4 and 5 periods among children and adolescents. Cases were symptomatic with a positive SARS-CoV-2 test, and controls were symptomatic with a negative SARS-CoV-2 test. We did not have enough vaccinated hospitalized children to assess VE for hospitalization, so this analysis focuses on ED and UC visits only. Next slide. This slide follows the same pattern as earlier slides, with children 5 to 11 years old on the top and adolescents 12 to 15 years old on the bottom, 2 doses in green and 3 doses in blue. And we have similar patterns here as we saw from Vision for these same age groups, with waning of 2 and 3 doses, though wide confidence intervals, especially around the 3rd dose. Next slide. Now moving on to VE for hospitalization. Next slide. These are results again from Vision, this time against hospitalization among immunocompetent adults. As we've seen from earlier variants, VE against hospitalization continues to be higher and more sustained over time versus less severe outcomes. Note that we've not included estimates for the 14 to 149 days after the 2nd dose due to small numbers of people recently finishing their primary series during the summer. VE during BA4 and 5 was generally similar to VE during BA2 predominance, and so far the 4th dose, shown in black at the bottom of the slide, appears to be waning somewhat more slowly compared with the 3rd dose, although again, confidence intervals are too wide to be conclusive. Next slide. Finally, I'll share data from our IB platform from December 2021 through July 2022, so representing the Omicron period. Adults ages 18 and up from 21 medical centers in 18 states are enrolled. Cases have COVID-like illness and a positive PCR or antigen test, and controls have CLI and a negative PCR. Next slide. This slide shows VE among immunocompetent adults during Omicron predominance, with dose estimates coming only from those, dose 4 estimates coming only from those 50 and up. As with Vision, we see waning of the 2nd and 3rd doses, though more sustained VE than against infection. Next slide. And finally, here we see VE against hospitalization among immunocompromised adults. Note that we did not have enough statistical power to estimate VE of 2 or 4 doses, so we've displayed only 3-dose VE with evidence of waning here. Next slide. Next slide. So to summarize, VE against severe disease continues to be higher and more sustained over time than VE against infection. VE during Ba4 and 5 predominance was generally comparable to VE during Ba2 predominance. A third dose provided significant additional protection against infection and severe disease in all ages. And while the third dose did wane, especially against infection, it appears to wane slightly more slowly compared to the second dose, with similar patterns seen across age groups. Finally, fourth dose coverage was too low to draw conclusions, but additional benefits were demonstrated against all outcomes, with slower waning apparent, especially against hospitalization. Next slide. I'd like to thank the individuals shown on this slide for their contributions, and I'm happy to take questions. Thank you.
Thank you so much, Dr. Linkellis. This presentation is now open for questions. I do not see any hands raised, so your presentation must have been very clear, and thank you for the efficiency on the presentation. Last call for questions. We can always, Dr. Long, thank you.
Yes. Let me just be sure I understood this correctly, because it says a lot about what we're talking about today. So did you, I even looked at them before, but I was still getting it when you were showing them, and you went so fast. It was wonderful data. I want to be sure I got this right and tell me for sure if I do not. It is that the effectiveness against B4 and 5 for hospitalization was equal to and had the same decay as it did against earlier. So there was no advantage for there would be no seeming advantage of a bivalent against Omicron 4 and 5 in the short run. We don't know about the long run versus hospitalization. Is that correct? Poorly said, sorry.
So these data were all the monovalent vaccine, so we didn't provide any data for bivalent. If you go back to slide 14, this is our hospitalization data in adults among immunocompetent adults. So again, this is the monovalent vaccine only, so the existing currently used vaccine. So you see BA2 on the top and BA4 and 5 on the bottom. Generally, the patterns are the same. I think I would caution against interpreting lower VE during 4 and 5 using these data just because of the wide confidence intervals. But I think we see the same general pattern that there is some indication of waning of the third dose. The fourth dose does seem to bump you back up, maybe even a little bit higher than the initial third dose. And again, these are much higher VEs and more sustained effectiveness for hospitalization than what we saw for infection. But I think that it's an indication that the bivalent vaccine should provide at least similar or better protection against Omicron, since it'll be a better match. But these data are focused only on the current monovalent vaccine.
Thank you. Dr. Palin?
Okay, yes. Thank you so much for this great presentation. I wanted, the way I was interpreting this data, and I'd like to have verification, is that really the primary series waned a lot. And it's the third and fourth doses of booster that provide important protection against our severe disease, even when you're using the monovalent vaccine. Is that correct? Thank you.
Yes, I think that interpretation would be correct. I think we've seen this pattern for every variant so far, that the primary series provides some protection, but that it's relatively limited and wanes quickly, and that third dose is really key for having more sustained protection, and early indications are that the fourth dose likewise provides additional benefit in those for whom it's recommended.
Thank you. Dr. Long, did your hand go up again?
Yes, it did. Thanks.
Okay.
I just wonder how confident you are about that last statement when I'm looking at this studies, and the average time since the fourth dose was 27 days, 38 days, and 84 days. So, 90 days before you saw there was significant waning, but considering the small number of subjects and the wide confidence intervals, tell me statistically, are you confident about that last statement, that not about what everything else has shown, but what this 4-dose 2 boosters has shown, that there is slower waning?
So I think the issue is that we have relatively limited follow-up time after the 4th dose just because of when it was recommended. And so as you say, the numbers are fairly low of cases that have been hospitalized after receipt of a 4th dose. So I think we can't really conclude here that there is or is not waning of a 4th dose. I think the basic indication is that you get a little bit of extra protection versus a 3rd dose, and certainly extra protection after a distant 3rd dose. So like compared to the individuals that got 3 doses more than 120 days ago, there's definite benefit of the 4th dose there. But I think it's too early to conclude one way or the other about waning of a 4th dose.
Thank you.
Thank you. And with that, let's move on to the next presentation. Thank you so much, Dr. Link-Ellis. We'll move on to Dr. Tom Shimabukuro, who will provide COVID-19 vaccine safety updates for the committee. Thank you.
Hi, could I go to the next slide, please? This is really going to be a 2-part presentation after I cover some brief background on our monitoring systems. I'm going to present on the safety of primary series mRNA COVID-19 vaccination in children ages 6 months to 5 years, followed by data on safety of mRNA COVID-19 booster vaccination in people ages 5 and older. And I'll actually provide the summaries after each of these individual sections. Next page. Next slide. One of the systems that we use is an adverse event reporting system, which I know most of you are very familiar with. VAERS is the nation's spontaneous reporting or passive surveillance system that's co-managed by CDC and FDA. Next slide. VAERS accepts reports from everyone, regardless of the plausibility of the vaccine causing the event or the clinical seriousness of the event. Key strengths of VAERS is that it can rapidly detect potential safety problems and can detect rare adverse events. The main limitation is because of the limitations of passive surveillance. Generally, we cannot determine cause and effect from VAERS data alone. Next slide. We'll also be presenting data from the Vsafe after vaccination health checker. Next slide. Vsafe is a voluntary CDC smartphone-based monitoring program for COVID-19 vaccine safety. It uses text messaging and web surveys to check in with vaccine recipients after vaccination. It solicits participants' reports on local injection site reactions, systemic reactions, and health impacts, and parents can register and complete surveys on behalf of their child. Next slide. Lastly, our vaccine safety data link system is our EHR-based system for surveillance and research. It's a collaborative project between CDC and 9 integrated healthcare organizations. Next slide. In VSD, we do rapid cycle analysis, which is near real-time sequential monitoring. The aims are to monitor the safety of COVID vaccines weekly using pre-specified outcomes of interest and to describe uptake of COVID vaccines over time in the VSD population. Next slide. So the first part of this presentation will be safety of primary series vaccination in children 6 months to 5 years. Next slide. This is a table of U.S. reports to VAERS among children after primary series, and for Pfizer, it's 6 months to 4 years, and for Moderna, it's 6 months to 5 years. That's based on the ages for the authorizations and the youngest children. For Pfizer, there's been 890,000 doses administered during the analysis period. For Moderna, 664,000 doses. There are 496 reports for Pfizer and 521 for Moderna. The key takeaway from this table is that 98% of these reports for both Pfizer and Moderna were classified as non-serious, and there were no reports of myocarditis for either of these vaccines. Next slide. These are the most frequent MEDRA-preferred terms to VAERS reports following primary series for Pfizer vaccination in children 6 months to 4 years. On the left-hand side, it's all reports, which includes these MEDRA-preferred terms that include PTs that are consistent with vaccination errors. You see they're highlighted in blue font. On the right-hand side, we have excluded those non-clinical outcomes. And then when you just look at the clinical outcomes, commonly reported adverse events are systemic reactions. Next slide. This is the same table for Moderna. This is for children 6 months to 5 years. And on the left-hand side, all reports to include those non-clinical terms, which are primarily error terms associated with vaccination errors. And then on the right-hand side, it's clinical outcomes only, and a very similar safety profile to that observed for Pfizer, primarily systemic reactions. Next slide. So moving on to Vsafe. In this table, you see Vsafe enrollment among children for following Pfizer and Moderna vaccination. The doses administered are the same as I previously mentioned, about 664,000 for Moderna, about 890,000 for Pfizer, and 14,725 children enrolled following Moderna vaccination, 8,541 children enrolled following Pfizer. Next slide. These figures show reactions and health impacts reported in children aged 6 months to 2 years, reported at least once in the 0 to 7 days following vaccination by dose. On the left is the figure for Moderna. On the right is the figure for Pfizer. Dose 1 is in the orange bar. Dose 2 is the blue bar. And I think what's important to note is that injection site reactions and systemic reactions are commonly reported. If you look at dose 1 for both Moderna and Pfizer, you get quite similar reactogenicity profiles. For dose 2, there's slightly higher reporting for injection site reactions, systemic reactions, and health impacts for Moderna, but we're not seeing that for Pfizer. And in fact, there may be slightly lower reporting for dose 2. We don't have dose 3 data yet available for Pfizer. We'll get that in the future as more time elapses. Next slide. This is a similar figure, but for children ages 3 to 5 years. And seeing a bit of a similar pattern here. Injection site reactions, systemic reactions are fairly commonly reported after both vaccines. The dose 1 reactogenicity profile for Moderna and Pfizer look quite similar. And then we're seeing some higher reporting for reactogenicity following Moderna, but not seeing that pattern for Pfizer. Next slide. So moving on to Vsd data. These are the Vsd COVID-19 vaccine rapid cycle analysis pre-specified surveillance outcomes and the settings in which they're monitored. Next slide. So through the analysis period, which is through August 13th, there's been about 50,000 Pfizer primary series doses administered. You see the breakdown between first dose and second dose, and about 52,000 Moderna doses administered. So just over 100,000 total primary series mRNA COVID-19 vaccinations in these age groups. And to date, there have been no statistical signals detected for any pre-specified surveillance outcomes for either mRNA COVID-19 vaccine. Next slide. So in summary, for primary series vaccination in children ages 6 months to 5 years, the initial safety findings of both mRNA COVID-19 vaccines are consistent with those observed in the clinical trials. Systemic and local reactions are commonly reported adverse events. Vaccination errors are also being reported to VAERS. There's been no unexpected safety findings to date and no evidence of an increased risk from myocarditis following mRNA COVID-19 vaccination in children ages 6 months to 5 years. Next slide. So moving on to part 2 of the presentation, which is COVID-19 vaccine safety of booster doses in people ages 5 years and older. Next slide. This is a summary table of U.S. reports to VAERS following first and second mRNA COVID-19 booster vaccinations for all mRNA vaccines combined. You can see there's been a substantial number of first booster doses and a decent number of second booster doses administered. Smaller number of first booster doses administered for children 5 to 11 years. And you see the male to female breakdowns, the serious, non-serious breakdown on the table there on the right-hand side in the right-hand columns. Next slide. So these are the most frequent MEDRA preferred terms in reports to VAERS following first booster dose in children ages 5 to 11 years. This is a similar format to what I showed you. It's all reports on the left-hand side there with error terms highlighted in blue. And then on the right-hand side, when we exclude those non-clinical outcomes, you see the top 10 clinical outcomes, which are mainly systemic and local reactions. Next slide. So a little bit different format on this slide. These are the most frequent MEDRA preferred terms in reports following first booster dose for ages 12 and older. So we have non-serious reports on the left-hand side and then serious reports on the right-hand side. And again, this follows the regulatory definition for serious. And this includes clinical outcomes only. Although I will say in these older age groups, proportionally, there are not that many error reports that we see with the younger age groups. So on the left-hand side for non-serious reports, the most common reports are local and systemic reactions. And then on the right-hand side, see that many of these serious reports likely represent COVID disease or signs and symptoms associated with COVID disease. You see vaccine breakthrough infection actually reported there at number 8. Next slide. So this is a similar slide showing the most frequent MEDRA preferred terms to VAERS following second booster dose in ages 50 and older. Non-serious reports on the left-hand side and serious reports on the right-hand side, clinical outcomes only. You can see for non-serious reports, there are COVID disease or terms associated with COVID disease are reported, as well as systemic reactions and local reactions. Then on the right-hand side, you'll see somewhat of a similar pattern where COVID disease, breakthrough disease, and signs and symptoms likely associated with COVID disease, commonly reported for serious reports. Next slide. These are VAERS report. This slide is VAERS reporting rates of verified myocarditis per million mRNA COVID-19 first and second booster vaccinations in the days 0 to 7 post-vaccination. So on the left-hand side there, we have boosters, and that includes 5 and older. And then on the right-hand side, we have second boosters, and that only includes individuals 50 and older. Where the cells are highlighted in peach, that's where the reporting rate to VAERS exceeds the background rate for myocarditis. So for males in the age groups 12 up to 29, we see elevated reporting rates for myocarditis compared to background rates. And then we are not seeing that for males in ages 30 and over, and not seeing that in any of the age groups for the females, and not seeing any elevated reporting rates for males or females for second booster dose in those individuals 50 and older. Next slide. So we wanted to include this slide because the most apt comparison may be what does first booster dose look like compared to dose 2. So the far right-hand column is actually from the previous slide, and then the dose 2 slide represents the reporting rates following dose 2 of the primary series. And I think the trend here is that the reporting rates for myocarditis per million doses administered in the days 0 to 7 post-vaccination are consistently higher following dose 2 compared to first booster dose. They exceed background rates in the age groups for males from ages 5 up through 49, and for females from 12 up to 29. So a general trend here that the reporting rates for myocarditis appear to be higher for dose 2 compared to first booster dose. I'll caveat that by saying that this is based on spontaneous reporting and is subject to reporting biases. Next slide. So moving on to data from Vsafe. This figure here shows reactions and health impact events reported by Vsafe participants aged 5 to 11 years at least once in the days 0 to 7 after homologous Pfizer vaccination by dose. So dose 1 in orange, dose 2 in blue, and then the booster dose. I think probably the take-home message from this figure is that reported reactogenicity, whether it's injection site reactions, systemic reactions, and even health impacts, tends to be fairly similar for booster dose compared to dose 2 for Pfizer in this age group. Next slide. And this is a similar figure, but it's for ages 12 to 17 years. And then again, similar to what we see for the younger ages. There is more self-reported local and systemic reactogenicity and health impacts. But again, booster dose reactogenicity appears to be fairly similar to dose 2 reactogenicity in this age group for Pfizer vaccination. Next slide. This is a similar slide for Vsafe participants age 18 and older. We include Moderna now because because Moderna is available in this age group. So Moderna figure on the left-hand side and Pfizer on the right-hand side. There may be slightly more reporting of reactogenic events following Moderna. The trend here is that the booster dose reactogenicity appears to be maybe slightly lower than dose 2 reactogenicity, but maybe a bit higher than dose 1. Reactogenicity, reported reactogenicity with Moderna may be slightly higher than for Pfizer, but the same general pattern here for Pfizer that we observed for Moderna. Booster dose reactogenicity may be slightly lower reporting for booster dose compared to dose 2. Next slide. And lastly, this includes the data for individuals 50 and older. And then for this age group, we have the second booster dose available. So dose 1 in orange, dose 2 in blue, first booster dose in green, and second booster dose in red. There, Moderna on the left, Pfizer on the right. There is a higher self-reported reactogenicity for Moderna compared to Pfizer. Dose 2 has the highest reported reactogenicity, and then for both vaccines, we see this trend of decreasing reported reactogenicity for the first booster dose and the second booster dose after dose 2 with the primary series. Next slide. So moving on to vaccine safety data RCA analysis, just to remind you of the pre-specified surveillance outcomes and the settings in which they're monitored. Next slide. So here's mRNA COVID-19 booster vaccine doses administered in VSD in people ages 5 to 11 on top, 12 to 17 in the middle, and 18 and over on the bottom. And for VSD, we're focusing on first booster doses. There's been about 94,000 booster doses in 5 to 11, about 265,000 in 12 to 17 years old, and then for 18 and older, about 2.2 million Moderna dose 1 booster doses, and about 2.8 first booster doses for Pfizer. Next slide. So in the 5 to 11-year-old age group for the first booster dose, there have been no statistical signals for any pre-specified surveillance outcomes. Next slide. So this table shows VSD signals for pre-specified outcomes in the 1 to 21 day risk interval after first booster in people 12 and older. And we have a statistical signal for myocarditis and pericarditis in the combined Pfizer-Moderna grouping there. So these are individuals who got Pfizer primary and a Pfizer first booster plus Moderna primary and a Moderna first booster. No signals for any other pre-specified outcomes. Next slide. So we do a more detailed analysis to assess this signal for myocarditis. This table shows verified myocarditis and pericarditis during the 0 to 7 day risk interval post-vaccination versus the comparison interval 22 to 42 days post-vaccination with first booster. And then for the 12 to 15 and 16 to 17-year-olds, it's just Pfizer data. And you can see there for males, 12 to 15 years old, there is an elevated adjusted rate ratio, which is statistically significant. And that translates, it's 18.5. That translates into 61.7 excess cases per million doses administered in the 0 to 7 day risk interval compared to the 22 to 42 day post-vaccination control comparison interval. And then for 16 to 17-year-olds, the adjusted rate ratio is not estimable because we have an 8 to 0 split, but it is statistically significant because the lower bound of the confidence interval is 2.03. And then for 18 to 39-year-olds, for males with the combined doses and males with primary series primary series Pfizer and a Pfizer booster, we see elevated adjusted rate ratios that are statistically significant. Next slide. So this slide is straight VSD incidence rates of verified myocarditis and pericarditis in the 0 to 7 days after Pfizer, and this table, vaccination in people ages 5 to 39 years, looking at dose 2 compared to first booster dose. So the incidence rates in the 0 to 7 days following dose 2 are on the left-hand side of this table, and then the incidence rates following first booster dose in the 0 to 7 days on the right-hand side of the table. For most of these incidence rates, the dose 2 incidence rate is higher than the first booster dose incidence rate. However, these are small case counts and wide confidence intervals, so not much statistical difference. There are exceptions. I will point to the 16 to 17-year-old age group, both for males and females, where we see a higher incidence rate following first booster dose compared to dose 2 for both males, 188 compared to 137, and for females, 36.4 compared to 9.3. However, again, these are relatively small counts and wide confidence intervals, so those estimates of the incidence rates are not statistically different. Next slide. This is a similar table, but for Moderna, we have data for 18 to 29 and 30 to 39 years old, which you see the estimates and the confidence intervals for the incidence rates there. Next slide. So in summary, for mRNA COVID-19 vaccine safety of booster doses in people ages 5 years and older, the safety findings are generally consistent with those observed for primary series vaccination. The evidence suggests an increased risk for myocarditis following first booster dose. However, myocarditis is a rare event following mRNA COVID-19 booster vaccination. CDC has verified 131 myocarditis case reports to VAERS in people ages 5 and older after 123 million mRNA COVID-19 booster vaccinations. The risk is primarily observed in adolescent and young adult males. There's no statistical signal for myocarditis to date in children ages 5 to 11 years following first booster. In VAERS data, the reporting rates of myocarditis are lower following first booster dose versus dose 2 of the primary series. And I will just remind you that the rates are higher, reporting rates are higher for dose 2 compared to dose 1 of the primary series. In VSD analyses, myocarditis and pericarditis incidence following first booster dose and dose 2 of the primary series are similar, though case counts are small and confidence intervals around point estimates are wide. Next slide. I'm going to finish up with a couple general slides on COVID vaccine safety, monitoring of pregnancy and reproductive health outcomes. We monitor pregnancy and reproductive health outcomes in multiple systems, including Vsafe, the Vsafe Pregnancy Registry, VSD, VAERS, and the Clinical Immunization Safety Assessment Project. Some of the outcomes or topics that we monitor are shown there on the left-hand side of this slide. Next slide. So to date, for outcomes studied, there have been no concerning findings for pregnancy and reproductive health outcomes following COVID-19 vaccination. Data on COVID-19 vaccine safety during pregnancy and reproductive health outcomes following vaccination will be presented at a future ACIP meeting. Next slide. I'd like to acknowledge the following groups and organizations for their contributions to this presentation. Next slide. Next slide. That concludes my presentation. I'll be happy to take questions.
Thank you very much, Dr. Shimabukuro. This presentation is now open for questions. Dr. Long.
Yes, I have two timing-related questions. The first is, do you have any information on the interval between first and second dose in those who got myocarditis or did not? And do you have any information either on just straight the interval between dose 2 and the booster in the population that you looked at? And it would be great if you also had that on those that got myocarditis or not. You see where I'm going, because this is so much more common after the second dose. We have to believe that some kind of underlying existing something, we don't know if it's antibody or if it's something else, predisposes to myopericarditis. So there's generally a bigger interval from dose 2 to first booster. And could you tell by what the interval was in those who got myopericarditis, whether that interval had any effect? The duration of the interval had any effect?
So for the interval between first and second dose, we know from VSD data that there's very little variability, and that the schedule was followed, so that there really isn't enough variability there to draw any conclusions. For the intervals between the interval between dose 2 and the booster dose, it's at least 5 months. And there also isn't that much variability around that. And the number of, the number of counts, the case counts for myocarditis are still pretty small, and we just I don't think we have enough information right now on interval to draw any firm conclusions about that. I think probably the best data come from Canada, where because of differences in the recommendations in the provinces, they had substantial variability between first and second dose of the primary series, and have data that the longer the interval between the doses, the lower the risk for myocarditis. So I think there is some evidence that extending the interval may reduce the risk of myocarditis. In the U.S., we just don't have that much variability, and for a pretty rare outcome, I don't think we can have enough information to draw any conclusions at this point. But it is something I think that that is worth looking into more.
May I ask a very short follow-up question, Dr. Lee?
Yeah, very brief, thank you.
Yes, and the brief follow-up question is, do you we're led to believe that probably as we get closer to the current time, at least 50% of these people in this age group have had natural disease with or without vaccine on board. Do we have any, first of all, are these data, do they extend into the Omicron surge where there's also a background natural infection? And do we know if natural infection is more common in those who have mild pericarditis at the booster stage?
Can you repeat just the last part of that question?
Do we happen to know if those that got the booster who got myocarditis were more likely to have had somewhere in the past, or especially the recent past, infection?
Documented infection in the EHR, electronic health record, is in these myocarditis cases is pretty rare. It's on the order of 10 to 11%, depending on what you're looking at. So it's not it's still fairly uncommon, and this data does go through at least some of this data goes through the Omicron period. I think it may be difficult because not every infection is necessarily captured in the electronic health record. So we don't know for sure if some of these cases may have been infected, but that is just not available in the EHR. But I don't think that we have sufficient data right now to draw any conclusions about whether having natural infection and then getting a booster may put you at increased risk for myocarditis versus somebody who hasn't had infection and gets a booster. I just don't think we have sufficient data right now to address that issue.
Thanks, Dr. Nabokoro. I see Dr. Klein raised her hand, then we'll go to Dr. Paling, Daly, and then we'll close the session.
Hi, thank you. I just want to briefly clarify that the myocarditis case definition, myocarditis pericarditis case definition for the Vsd does exclude individuals who had a current COVID infection in the 60 days prior to the myocarditis, if we know about it. But Dr. Schmidt-Becker is right that there's a lot we don't know about. But for those we know about, we do exclude those from the Vsd case definition.
Thank you. Dr. Paling?
All right, Dr. Shimon-Bakura, thank you for this great presentation and all the work that you and the teams have done to share so much data on safety of the many millions of doses that have been administered. I really have a comment, and I wanted to thank you for sharing the VAERS data and the number of reports of vaccine administration error in the children less than 12. We know there's lots of, and before the approval, we talked about our concern about the likelihood of error because the files look so similar. And so I just wanted to highlight that and encourage as we move forward to have more distinct files to make vaccine errors less common. Thank you.
Thank you, Dr. Paling. And actually, I know we have both manufacturers on the call for later in the agenda, so maybe we can come back to this question and ask if they could please respond. Dr. Daly.
Yeah, thanks so much. Dr. Shimabukuro, my question was closely related to Dr. Paling's. I have two questions, but they're both brief. One is, can you put those vaccine administration errors reported to VAERS in context of other vaccines? Is this partially a function of a new vaccine, or is it really more a reflection of different doses at different ages? And then I have a follow-up question.
I think we have evidence that when a new vaccine appears on the market, or there's a new recommendation for an age group, we do see an increase in reports of errors to VAERS while during that initial uptake period, while providers are getting used to the products, and that tends to then decrease. And so we may be in that phase where we're seeing a lot of errors right now, and that may be that the problem may be magnified a little bit about a lot of recommendations coming rapid fire, and then maybe some issues around the packaging. But it's not surprising to us that we are seeing a substantial number of reports, error reports early on when there's a new recommendation in a new age group.
Thank you. And then my follow-up question is, what do we know about serious adverse events among those who experienced a vaccine administration error? Thank you.
The overwhelming majority of these error reports do not report an adverse health event, and when there are adverse health events associated with these error reports, they tend to be similar to what we see in general. In fact, I'm just looking at least for the ages 5 to. There are very for the youngest age groups, there are actually no serious adverse events associated with one of the error reports, and then for the 5 to 11-year-old age group, there were only 4 that were classified as serious. And when we looked at these, although they met the regulatory definition as serious, they didn't appear to be clinically serious, so that we don't really have any concerns. I think the one concern we might have is if a child gets an adult dose of an mRNA vaccine, does that put them at increased risk for myocarditis? But we haven't seen a case of that happening.
Thank you. And thank you for those questions too. Thank you, Dr. Shimabukuro, and to all of our speakers during the morning session today. We are slightly behind schedule, so I'm going to give us 10 minutes and ask that we meet at, we'll say 20 minutes after the hour to reconvene for public comment. Thank you, everyone.